So the esophageal cancer, especially the squamous cell carcinoma, is mainly arise from the Eastern Asian countries. And many esophageal squamous cell carcinoma patient is in Japan. And the prognosis of the esophageal cancer is poor. So even for the local cases, we commonly used for the neoadjuvant therapy for such kind of the patient. And in the Western countries, the neoadjuvant chemoradiotherapy is a standard of care for such kind of patient. But in Japan, the JCOG1109 trial shows a positive effect of the neoadjuvant chemotherapy over the adjuvant chemotherapy. So our standard of care was neoadjuvant to course of the 5-FN cisplatin followed by surgery. And we conducted our study JCOG1109 to enhance and prolong the prognosis for the esophageal squamous cell carcinoma patient. To enhance the neoadjuvant trial and improve the outcome, we hypothesis of the two hypotheses for the more intensive neoadjuvant treatment. So one is the stronger local control by the radiation therapy, like cross trials using the Western countries. So one experimental arm was the chemo plus radiation arm as a neoadjuvant therapy. And one more experimental arm is a more intensive systemic therapy using the triplet chemotherapy, 5-FU cisplatin plus docetaxel. This combination triplet therapy is already used for the induction chemotherapy for the head and neck carcinoma. And they show the positive result as induction therapy over 5-FU cisplatin. So we set the standard of care as a 5-FU cisplatin and the DCF and CFRT and the two experimental arms. So our trial has 3 arms and 1 standard of care and the 2 experimental arms. And we assume the 10% increasing at the 3-year survival from the 62% to the 72% at the for the experimental arm. So we calculated sample size as 200 patient for each arm. So we started collected the ESCC patient from the 2012. Enrollment was terminated in the 2018, and after the 3 years follow-up, the overall survival comparison was done. And for the control arm, the 5-FU cisplatin arm, the 3 years overall survival rate is 62.6%, and the DCF arm shows 72.1%, and hazard ratio was 0.68, and the p-value was less than 0.025. That means the statistical significance on survival benefit. On the other hand, the CFRT arm shows 68.3% of the 3 years overall survival rate. And in the comparison to the neo or 5-FU cisplatin shows a hazard ratio of 0.84. That's not statistically significant. So among the 2 experimental arms, only DCF regimen shows a survival benefit over 5-FU cisplatin. And the CF plus radiation arm that did not show the statistical significance over 5FA and cisplatin. So that means the more intensive systemic therapy shows a more improved survival of the locally advanced esophageal squamous cell carcinoma patient. This means the radiation is a very strong treatment for the esophageal squamous cell carcinoma, but sometimes the harmful for the patient after the surgery. So our findings show that the patient died by the other cancer or unknown reason cancer is a more more common in the chemoradiation arm than the other chemotherapy arm. So that may the radiation but the not so high. Yeah. Maybe that 10 or 20% of the patient died with the toxicity of the radiation therapy. So the more systemic control would be affected for the long-term survival of the ESCC patient. And more, the CheckMate 577 trial shows a positive effect for the esophageal carcinoma as an adjuvant treatment. And more, so we expected the additional effect for the immune checkpoint inhibitor as a neoadjuvant chemotherapy. And the recent phase 2 trial shows the additional the efficacy of the immune checkpoint inhibitor to the neoadjuvant chemoradiotherapy of the esophageal cancer is not so high. So I think it is better for the combinator of the immune checkpoint inhibitor as a neoadjuvant chemotherapy rather than the neoadjuvant chemoradiotherapy. So further investigation with immune checkpoint inhibitor to the neoadjuvant chemotherapy would be expected. So in this trial, the surgical procedure is slightly different from the Western countries. As a discussant of the ESMO GI symposium was pointed out, the harvest number of the lymphocyte is the more in the Japan procedure than the Western procedure. So because for decades, the more intensive lymph node dissection is a standard procedure in Japan, but mainly the Western countries, not so much intensive radical lymph node dissection was not performed. So that's different from the result of the Western and the Japanese result. So the local control of the ESCC was already done by the radical lymph node dissection. So the magnitude of the radiation therapy was less than the Western countries, I think.